Section 2. Who am I and why I think that matters. I identify as an Appalachian. My grandfather was part of one of the pioneer families who came here 380 years ago, shortly after the Mayflower, and my grandmother was a Kentuckian who left in what was known as the Hillbilly Highway looking for better opportunities when she met my grandfather. I was also born and raised in Appalachia. I'm not blaming everything that happened on cultural differences, but I believe this played a part in what happened. I have a hard time explaining myself, so I will reference some writing done by others. I will first start by quoting the author Rukhsana Ahmed, I hope I said that right, who wrote a paper called Assessing the Role of Cultural Differences on Healthcare Receivers' Perceptions of Healthcare Providers' Cultural Competence in Healthcare Interactions. On page 90 he writes, Appalachia is a 200,000 square mile region of the United States. Appalachia encompasses all of West Virginia and parts of 12 other states. 25% live in counties adjacent to metropolitan counties, while the balance, 15% of the population, live in more remote rural locations. People in Appalachia come from different backgrounds, including Native American, Irish, English, Scotch, German, and Polish backgrounds, among others. The mountains also factor into the Appalachian identity. The mountains entail both uniqueness and stereotype. The mountains kept Appalachia isolated from the rest of the U.S., separating Appalachians from other people's involvement in their lives, and allowing the Appalachians to assume a distinctive culture. To understand Appalachian culture, the adverse socio-economic conditions in the region, and the resulting health disparities, it is important to take into account the history of the region. People in Appalachia have suffered from dependence on extractive industries such as oil, coal, mining, and timber. Because these industries did not invest in human capital, but yet did extract the resources enjoyed many years of prosperity, Appalachia has been both exploited and underdeveloped. Weller identified 6 personality traits of the Appalachian mountaineers, including individualism, traditionalism, fatalism, seeker of action, the psychology of fear, and person orientation. Weller argued that for a mountaineer, the idea of individualism entails being independent and self-reliant. As Weller explained, these people reverted to a system of private justice based on the personal relationships common to the clan. They thus developed a general ideology of leveling, a system that gave equal status to all and that recognized no authority other than the force of the individual. Traditionally, Appalachians maintain a low profile and prefer to manage their own problems. Valuing traditionalism, the mountain people are bound to their past where values are held firm. Weller argued that a mountaineer is contented with just getting along, satisfied when his survival goals are achieved. The mountaineer seldom looks beyond them. This view is shared by Bauer and Growick, who wrote, In Appalachian America, professional labels and titles generally do not mean as much as how the person acts and relates to other individuals. Weller described the fatalism of the mountain people as more of a religious and emotional condition. He argued that the mountaineers faced hardship and poverty on a daily basis. This deprived condition made them accept a fatalistic outlook, which does not allow much room for questioning and complaining, but ensures compliance. This fatalistic stance finds expression in statements such as, if that's the way God wants it, I reckon that's the way it'll be. We just have to take what the Lord sends us, He knows best. Even though fearlessness is being portrayed as a typical personality trait for the Appalachian mountaineers, Weller argued that the mountain society is filled with apprehension. Weller described the mountaineers as person-oriented individuals who are sensitive, who value relationships, and who tend to reject materialism. Although these traits apply to demonstrate many of the Appalachian mountaineers, Weller argued that it is problematic to consider Appalachia a homogeneous region. He also admitted that many of these characteristics also fit many non-Appalachian Americans. In his words, I am portraying some general tendencies of behavior in the mountaineer. Because of its geographic makeup, Appalachia is a diverse region encompassing many different cultures. However, many studies suggest that some common values hold this region together. In her study of mountain identity, Keefe argued that mountaineers clearly conceptualize themselves as a people, albeit socially diverse, with a common culture and identity. Since cultural identity and social class identity are not mutually exclusive concepts, Both must be taken into consideration for a more complete understanding of a cultural group. The sense of mountain identity as being self-reliant, trustworthy, and interpersonally oriented with moral standings and deep-rooted heritage that Keefe reported in her study did not differ from Weller's understanding of the mountaineer. Although the Appalachian people are very diverse along the urban-rural spectrum, they are bound together with a common heritage and common values. Appalachians are a group of people who take pride in being self-reliant and having strong family values. Traditional Appalachian culture is not necessarily inferior to mainstream American culture, but is simply an equally good and rational way of life, which must be understood on its own terms. Appalachians are independent and self-reliant. They expect others to respect their freedom. Appalachians have a strong association with the geographical area that they live. They seem to be very close to nature and have a deep sense of spirituality and belief in God. Appalachians also have a strong sense of mistrust of anyone who is new or a stranger. Although they display friendliness, mountain people as a whole are resistant to change, slow to accept outsiders, and are very reluctant to accept authority. No hierarchy, authorities, or experts were allowed to form in this society. No pressure from outside was allowed to gain entrance. Because they attempted to avoid outsiders and outside influence for many years, the mountaineers were isolated from mainstream America, and Appalachia's rich cultural heritage was preserved. Alright, that's pretty much it for this document. So now that you should have a little better understanding of the person I claim to be, let me quote a Dr. David H. Loof, who wrote a paper called Assisting Appalachian Families, to better explain how culture plays a role in healthcare. On page 102, he writes, "Ultimately, in Appalachia as anywhere else, it is the people that make the area important. It is the people of the southern mountains in the region or in the places to which they migrate who are the makers and carriers of their society and culture. The living conditions of the very poor in Appalachia, their apathy, which is a form of chronic depression, and the meagerness of resources have often forced medical care into inadequate, symptomatic, crisis-oriented patterns. Nothing has occurred in these encounters of failures, for that is what these abortive attempts to give and receive some sort of aid really are. Because people's lives have not been touched, the helping professional feels rebuffed, unwanted, and unfulfilled as a helper. The potential recipient of the full measure of his aid, the Appalachian person in need, comes away from such an encounter feeling equally misunderstood and further rejected." Thomas Ford points up several aspects of this barrier of resistance between the helping person and the family of the Appalachian lower class. It is extremely difficult for outside agencies to reach these families that most need their help. Community institutions, it has been noted, are not traditional mechanisms for handling personal problems in Appalachia. Numerous studies have documented that poor families do not participate much in community organizations of any type, including the church. And because the personnel of these institutions are themselves often strangers, they frequently generate ever greater insecurities on the part of those they are trying to serve. We have rather dramatic evidence of how traumatic a new experience can be to Appalachian children, especially when it must be faced apart from the family. The exaggerated fear of the unfamiliar institution is not confined to children, though. Stories abound of the very real apprehension and anxiety of adults forced by circumstances to utilize the services of an unfamiliar organization such as a hospital or a government agency. The characteristic lifestyle of the person in the Appalachian lower class, with its trained individualism, traditionalism, religious fatalism, action orientation, and stoicism in manner and speech, work towards an inner directness that cuts the person off from community institutions and from cooperating participation with a stranger in meeting, defining, and attempting to solve his problems. This failure of many of our community institutions to reach the Appalachian poor was painfully demonstrated for the writer years ago in both the general health care and the mental health field. In the late 1950s and again in the early 1960s, the writer was a trainee in a large university-based community-funded child psychiatric clinic in Baltimore and Cincinnati. Both of these children's clinics were conducted in large hospital settings and both ostensibly served, among others, families of the Appalachian migrant poor. The writer's experience in both clinics sharply highlighted Ford's remarks. Migrant families were referred in great numbers to these agencies, but a majority of them did not return after meeting the large, strange staff in the unfamiliar setting and after encountering insistence on regular appointments for their succeeding visits. Too often, the writer feels now, these clinics, like many other community institutions that try to reach the Appalachian poor, took the position that their responsibility ended when the families had demonstrated low motivation for self-help by failing to return for care. Clinic services were available only on a take-it-or-leave-it basis. The customary rationalization of this position was that the clinics simply had insufficient staff to do otherwise. In one clinic, personnel were acutely aware of their failure to meet the needs of the Appalachian migrant poor, but were at a loss as how to break through these barriers of apparent apathy or resistance. The initial point at which these healthcare agencies failed in delivering health services to Appalachian migrant families was their lack of understanding of the lifestyle of these families. The personal orientation of the mountaineer steeped in familialism makes it very difficult, virtually impossible at first, for him to relate to total strangers in unfamiliar agency settings. In addition, his aversion to routines and to the agency's time-oriented casework schedules generally guarantees that he will not cooperate with the agency. This raises the question as to whether the particular lifestyle of the person in the Appalachian lower class forever precludes his receiving help from various community institutions. My experiences in Baltimore and Cincinnati were ones of sharing many failures with my colleagues in the urban agencies. However, the experiences I have had in helping many families and their children through the Manchester Project, as our field clinics are called, over the past 11 years have erased forever from my mind any doubts that all kinds of health services, and presumably other types of services as well, can be brought effectively to Appalachian families. The essential difference between my experience of clinical failure on the other hand and clinical success on the other is not, I feel, any factor that resides in me as a person or as a child psychiatrist. Rather, the essential difference that spelled relative success in the Manchester Project was a different point of view of the work itself. It took squarely into account the fact that the Appalachian people are person-oriented. Their characteristic of orientation to the self, to the intimate, and to the personal proved to be the point at which community agencies can begin to relate to them. At the outset of our project, the local health officer and the nursing staff discussed local attitudes towards healthcare and some of their underlying causes. They pointed out that patients from mountain areas are almost overwhelmed by the scattered specialized facilities of the large hospitals and medical centers far from their homes. From time to time, families have had to be referred to these centers for needed diagnostic and treatment services. These families were frightened when away from their area and kin, by what they viewed as relatively impersonal institutionalized services. For these reasons, the nurses pointed out to us, Appalachian families tend to differ from the majority of Americans who want to and therefore can accept healthcare service wherever it is available. Our first impression of this inherently strong capacity Appalachian families of all three social classes have for trusting relationships was gained from their children. They related very well in clinic interviews, in their schools at the time of our consultation visits, and in their homes. Any initial reserve was soon dropped. For example, their capacity to relate led them to wait quietly, even with non-anxious anticipation for their dental appointments in the health departments, and for preschool physical examinations by unfamiliar visiting pediatricians. Most of us, as urban physicians, are accustomed to the waiting room crying and restlessness of young children. Thus, I was at first surprised to find Appalachian children waiting quietly, without crying, or excitedly giggling with each other. Adults, too, related well with others, although the thawing out period was sometimes longer than the time required by the children. Once their initial reticence was overcome, however, parents made good use of the relationship. In time, they were able to involve themselves in interviews with remarkable warmth and candor. Although many families were geographically and culturally outside the mainstream of county life, generally they related with us no sense of personal isolation. In fact, their relatedness often combined such warmth, openness, and earthiness that we were reminded of the traditional spontaneity of young children. Gone were the layers of sophistication, telling the physician and others what families think should be said, that so often mark and impede initial treatment interviews with urban families. Our conclusion from reviewing the developmental backgrounds of many children in the lower class in Appalachia was that these children are well trained in basic relatedness from infancy on, but are not well trained in acquiring controls over their aggressive impulses. During the infancy period itself, lower class families as well as the others freely gave of themselves to children. As an outgrowth of this, the children retained a considerable measure of the ability to relate with others in spite of difficulties with other capacities. The implications for the mental health and general health fields of this capacity for relatedness should not be underestimated. All forms of health intervention involve the giving and the taking of help in an interpersonal context. In my experience and that of others, the relationship capacities of Appalachian families are very real indeed, and these capacities are not dimmed by the family's migration to other settings. Presumably, then, those who work in any helping capacity with Appalachian families, either locally or in another setting, will find mutual relationship a powerful working tool. For when this capacity is combined with an initial approach that respects the Appalachian individual's orientation to the intimate, the sensory, and the personal, true personalization of services has been initiated and relationships are begun. After the introduction has been personalized and relationships are begun, services of all types can then and only then be brought into focus. The Appalachian individual is thus interested primarily in the helping person and that person's acceptance of him, and only secondarily in what the person has to offer or suggest. This way of orientating his priorities, and ours as helping professionals, is a direct outgrowth of the Appalachian person's training and familialism. The second consideration or ego shrink, that of the intense feeling and orientation of Appalachian adults and children, is similarly a derivative from early child development in the region. Children are trained from infancy on to orientate themselves to feelings rather than to words. This orientation to feelings is yet another aspect of the Appalachian person's action orientation. Actions speak louder than words, and a man is judged by his deeds, not his words, are but two ways of conceptualizing this orientation. Again, an orientation to feelings is a natural outgrowth of the Appalachian person's orientation to the intimate, the sensory, and the personal. In addition, what I've elsewhere called regional nonverbality, a very important child development theme in the Appalachian region, particularly among members of the lower class, is a powerful social reinforcer of this orientation to feelings rather than to language. Although space does not permit a full discussion of how difficulties arise among lower class Appalachian persons in using language as a tool, it can be said that the use of language in the region presents some striking contrast. On the one hand, there are clear indications that many people in the region find verbal communication very difficult. Theirs is an economy of language amounting to sparseness. This stereotype of the Appalachian mountaineer as a silent, taciturn individual is based on this difficulty. Neighbors of these people characterize them graphically as quiet-turned. In our field clinics, we have followed a number of the silent members of these relatively silent families. What we have found is that the most severely strained individuals and families are the ones who show the greatest lack of verbal communication. We and others feel that this explains why families in the lower and working class in Appalachia, the families having the greatest strains, have the greatest problems in using words as tools. Alright, this is almost over. I'm done with this document. The last thing I will show is a slide about Appalachian culture from a presentation from the West Virginian Center for Excellence in Disabilities called the Appalachian Culture Module. There's just a few things I want to point out here. Risk factors for Appalachians include heart disease, stroke, accidental injury, respiratory illness, and cancer. Common Appalachian values: independence, self-reliance, modesty, dislike of assertiveness or aggressiveness, minding one's own business, equality, avoidance of disagreements. Rural residents are more likely to describe their overall health status as fair/poor than urban residents. More present-oriented. Healthcare providers should ask the meanings of words that are misunderstood rather than making assumptions. May have strong sense of spiritual connection to nature. Health is a result of chance, sickness is God's will, and healing is a sign of forgiveness. Life and its events are predestined, with the individual having little control over events in life. People are likely to consult with family members before visiting a formal medical setting for treatment. Hospitals may be feared and viewed as a place where one comes to die. Persons may come to the hospital only when a health crisis occurs. A state of illness may only be perceived as an illness if the person subjectively feels ill. May appear stoic, often relies on healthcare provider to interpret nonverbal clues, may have difficulty precisely describing emotions or types of pain. Strong sense of familialism. Healthcare decisions may be delayed until family members can be consulted. At least one family member is likely to accompany the client to the healthcare facility. Healthcare providers may need several social patient interactions before the patient will be willing to discuss personal issues and problems that need interventions. Provide consistency in caregivers. Allow the patient and family adequate time to describe issues and problems within the context that they see them. The healthcare provider should exhibit an unhurried approach. Personalism is valued among Appalachians. May be very hesitant to consent to autopsies and organ donations. Patient education must be consistent with the client's frame of reference, or suggestions/instructions may be rejected. And that's it. As a migrant Appalachian, I've had to be able to adapt like many migrants before in order to fit in. Before of all this, I did not recognize how much being an Appalachian is such a huge factor of who I am. But I think it certainly explains why I did what I did. And because of my experiences, mainly my father who gave himself freely to others and accepted help freely in return, I did have some trust for strangers, despite my grandmother telling me my entire life that I can't trust anyone. But after this, I will never be able to trust anyone other than my family again. I also think I should note that while I do not believe in a traditional Abrahamic God, I identify as agnostic, meaning I do believe in something, I just don't know what it is. Alright, and that ends this section. Thank you.